I'll go first. My name's John Spivey. I'm a pediatric pulmonologist and sleep medicine physician here at Mercy in St. Louis. And what I'm going to do is I'm going to share my screen. I'm hoping everything goes pretty well. Can you guys see that? Let me see. Can you guys see that?
Yeah, we can see it.
All right. Well, I will start with the lecture. I guess with my dual monitors, I'll be honest, I lost the, I guess, chat function or the other folks. So I guess if you need anything, Julie, I guess, yeah, just kind of let me know. What I'll do is I'll just kind of go through these slides and then I'll answer any questions that everybody has at the end. If you want to interrupt in the middle, it's just us. So I'm pretty laid back with this. This is my daughter, Sophia, and this is my son, John. This was actually years ago at one of our first trips down to Memphis. You can see they're in a pack and play. And what I've realized being a physician, a pediatrician, and a parent is what I hope you guys learn today is pediatric sleep is a phase. There's different phases with each one of these. And what we'll do is we'll kind of go through why a child might have a particular problem during those different phases. So I want folks to know that children are not tiny adults. As pediatricians, we know that kids are just different. They're not small adults, but we'll review normal sleep and sleep development from infancy into adolescence. We'll talk about sleep hygiene and what we should be telling our students and children. We'll review some common behavioral sleep encounters in pediatrics. And for a few pediatric specific topics from sudden infant death syndrome to true medical concerns such as sleep apnea as well. So I do work here at Mercy, and a moderate part of my time is seeing patients in the hospital. And Jonathan, being one of our sleep technicians, knows that I'm interpreting sleep studies as well, but really nothing to disclose today. I'm hoping you enjoy this sleep lecture. I'm from the era of David Letterman, and a lot of people, including my own kids, do not know who David Letterman is, but I like to think kind of why is pediatric sleep important in kind of a nice top 10 list. As people probably are aware, sleep problems are common. 25% of children have some sleep-related problem in childhood. And if you think about it, kids sleep much of their day, 80% for infants. Even our adolescents should be getting maybe 30% of their time in sleep. As you know, with busy adolescents, that's not happening all the time. I think with appropriate education and knowledge, sleep problems can be prevented, they can be treated, and they're often one of the number one sources of parental concern and anxiety. Not being a general pediatrician, but obviously with general pediatric training, probably the two concerns I would get the most would be either sleep problems or feeding problems. As we all know, sleep is important for optimal growth and development. Sleep is important for appropriate social development. And sleep is often overlooked, especially if it's not affecting the parents. So what's funny is if a parent comes to me saying, I'm having trouble with my child's sleep, it's often behavioral. And that's something that I want everybody to be kind of on the lookout for. It's not always behavioral, but obviously if a child is waking up in the night and is bothering the parent because, that's when I see these children, but often that's more of a behavioral, not a medical issue. As you know, sleep problems can exacerbate all medical conditions in childhood, and one may consider sleep problems continuing into adulthood. Is this a public health issue? Because we all know the dangers of drowsy driving. We all know the dangers of some of these issues, especially in young adults and in adults. So one of the questions I get is, what is normal in pediatrics? So we know that sleep is important, but defining what's normal has to be individualized for the patient. I can talk to someone and I can tell them, well, do you have the right amount of hours, or is it the function of the child that you want? The developmental age, as we'll learn about, is awfully important with the amount of sleep and what's important as far as sleep. You know, if I dive in and be more of a sleep physician, I can tell you there's different physiological changes with a sleep study as well. One of the best things, though, I try to think about is this interplay between biology and culture, or almost a goodness of fit model. You can imagine our sleep and our sleep requirements in the westernized world is much different than, let's say, countries that take a siesta. Or my family was able to go to Greece 2 years ago. And funny enough, they will close the entire town down to actually go and take a break and take a nap. And then they'll come back and open up the stores. So you can imagine there's differences in what is required for a society and what was required for an individual. So it's really that interplay between biology and culture. So this is a slide that most people should have. And these are easy to find. You can probably just Google National Sleep Foundation sleep durations. And as you can see, the blue is what's recommended. The green is maybe appropriate. And then typically, if you're in that yellow range, that's probably not enough sleep. But as I mentioned before, the newborn and the infant is sleeping much of their day. The toddler and preschooler are still sleeping more than potentially half of their day. And as you can see, even a teenager should be getting 8 to 10 hours of sleep. And the typical recommendation is 9.25. So you can imagine some may be sleeping a little bit more than that. Some should be sleeping a little bit less. But if they're in that yellow range, that's typically not recommended. Here's another way to look at it, at kind of that healthy duration of sleep, because again, most of us think first about duration, but duration in itself is not the entire picture. And again, if you look at infants to teenagers through adults, we all have different types of durations. So these little people are not little adults. They have different requirements as well. The other thing that I think is important is how do we sleep is vastly different as we get older as well. And you can imagine that newborn infant is sleeping much of their day, waking up just to interact for a bit or maybe to eat. The infant that becomes the year-old child often is now consolidating his sleep a little bit better, at least we hope for the parent, taking on average maybe 2 naps. And then that 4-year-old has probably already dropped that nap, or probably that 2 and 3-year-old has already dropped that nap and getting most of that sleep consolidated. Now the 10-year-old is usually, funny enough, our children in elementary school, we consider them kind of our best sleepers, believe it or not. And as you can see, they're consolidating much of their sleep. Typically, they are not taking naps during the day. And then as an adult, you can see that shifted circadian rhythm to now they're probably going to bed more around 10 or 11 or closer to midnight. And maybe they're waking up also around 6. So as you can see, the wake sleep pattern is different as well. The other thing that's a little bit different that I just want to kind of throw out there, and this is more of that sleep physician, is there's different types of sleep, such as REM sleep and non-REM sleep. And look at that vast amount of REM sleep in the infants. Believe it or not, they can actually go into sleep in REM. Obviously, if we see that as a young adult or a child, we're worried about something like narcolepsy or something like that we can't control our REM sleep. But as we get older, you can see that REM goes from 50% as an infant to maybe 20% as a young adult or adolescent. But look at all of this non-REM sleep as well. Isn't it interesting that the non-REM sleep peaks kind of in that 2, 3, 4-year-old range? What if I told you that's when we often see common parasomnias? And parasomnias are activities often in non-REM sleep. Maybe your child's a sleepwalker, or a sleep talker or night terrors, well, it shouldn't surprise us that the peak incidence of these things are occurring at that age group in coordinates with the non-REM sleep. So again, more you know about sleep, the more you know about pediatrics. A lot of these things kind of go hand in hand. So one of the first things that we worry about, or we hope to talk to families about, is good old-fashioned sleep hygiene. And what sleep hygiene is getting the bedroom ready for sleep. And probably the number one thing that I hear the most about is the digital media. And the American Academy of Pediatrics has recommended turning off your bedtime electronics a good 30 minutes to an hour before bedtime. The reason for that is study after study after study shows that children sleep better without having electronics in their face, or even having this blue light go back to their brain and kind of affect some of their circadian rhythm. So one of the things that parents should hear is really turning off those electronics before bedtime. I, funny enough, had a TV in my bedroom, but again, that was years ago. So, not having TVs in your room, managing the electronics is really important. Some other specific, easy to do pediatric things is try to use your bedroom for sleeping. I know a lot of times parents will have punishments and timeouts in their bedroom. But if possible, if you can kind of make that bedroom kind of a haven for good sleep and make it kind of a happy time, that might actually help long term. Good old-fashioned regular bedtimes and routines and wake time is very important, especially for our adolescents. Our adolescents often stay up all night, maybe playing on electronics, and then they sleep in during the day. And you can imagine their bedtimes and night times are off. But that's something that I think having a set wake time, both for the weekdays and weekends, can be very helpful. One of the keys that you'll learn about is putting your child down drowsy but awake. All of those funny Facebook videos and all those videos that we see that parents rock their child to sleep, or they sleep with their child and they tiptoe out of the bedroom like ninjas, and we all laugh and we all go, oh, how funny that is. It's not the right way to put your child down, because they don't learn how to fall asleep on their own. The most common behavioral insomnia of pediatrics is what we call sleep onset associations, and we'll talk more about that. But you have to remember, these children have to learn how to fall asleep. So having a bedtime routine is okay, but you should walk out of the room and they should still be awake, and allow them to be drowsy but awake. And obviously having a quiet, cool environment can induce good sleep as well. So I'll talk briefly about SIDS and safe infant sleep. This has been an update from 2011. And this is one of the #1 causes of infant death beyond the neonatal period. And by definition, it's the sudden death of an infant under the age of 1 after all these other potential medical problems have been unexplained. So this includes an autopsy, an evaluation of the death scene, a review of clinical history. So this is not someone that had some poor genetic issue. These are typically healthy children that died of SIDS, and it's unbelievably tragic, and it's very, very sad. What we have found, which actually started from a historical standpoint back to I believe a nurse in New Zealand, found that if you put children back to sleep, so you put them on their backs, the incidence of SIDS goes down. So that's why years ago, really back in 1994, we started talking about this back to sleep campaign. And that has saved more children and more infants than any other interaction that we've had in pediatrics. So it's fascinating that an observation became kind of a set golden rule to promote healthy sleep. Now, again, this is for typical children. We're not talking about children with genetic issues, maybe a child with Pierre-Robin's, things like that. So we're not talking about children with craniofacial issues that may need other special support, but putting your child back to sleep is something that has been very important for us sleep providers. What are some other things? Well, sleeping on a firm surface, avoiding soft objects in the bedding, avoiding smoking, either maternal smoking or secondhand smoking. And one of the keys to sleeping is we talk about a separate but proximate sleeping environment. So kind of that idea of room sharing without bed sharing. And this goes against some cultures. There's a lot of cultures out there that believe in the family bed. And so how I support that is I'm a supporter of the family bed if it's culturally appropriate, but I don't support it in the first year of life. If you want to design a family bed for a 3-year-old or a 4-year-old or a 6-year-old, meaning the whole family sleeps in the same bed, I'm okay with that, but not as an infant. So I believe in your first year of life, you should have a proximate but separate environment. Consider a pacifier. Breastfeeding is recommended. And typically, I get a lot of consults for cardiac apnea monitors. I hate to say it, cardiac apnea monitors are a fantastic item to evaluate for apnea. We often have very chronic, complex children that we're looking at oxygen saturation, but just a cardiac apnea monitor alone does not prevent SIDS. So when I even prescribe a cardiac apnea monitor for maybe one of my premature babies or one of my complex children, I try to encourage the family to also know infant CPR. So this is actually a tigraphy, and I kind of put this up as kind of a fun slide. As a parent, if you've ever had children before, they don't sleep. That term sleeping like a baby just does not occur. So some parents are very lucky and very fortunate, and you have the ability to consolidate your sleep by 3 to 4 months. But remember, it's not the norm. So I get a lot of referrals for a 4-month-old or a 5-month-old that's not sleeping through the night. And I have to say that's still within norm, within the normalcy. Typically 70 to 80% of infants can sleep through the night by 9 months of age. So you may be a parent that's lucky and you get one of those really good sleepers that are self-soothers and they can soothe themselves. Or you may be a kiddo that's, get a child that's still waking up in the middle of the night, even at 11 or 12 months. It still could be considered within normal limits. So these are some other medical conditions that I probably would recommend asking for help. If you have high-risk infants such as trisomy 21 or some other type of genetic issue, interesting, we have achondroplasia on this list, craniofacial abnormalities, developmental delay, sickle cell anemia. Those are some things that probably should see a sleep specialist pretty quickly. There are other issues that can result in nighttime awakening, such as GERD or colic. And if you've ever had a child with colic, I became a believer in what colic truly is. So my daughter had colic, and funny enough, in a switch, it all went away. So I was actually a pediatrician giving parents advice on colic before I had a child with colic. And let's just say my view on colic is a lot different. It's a real entity. There's a rare entity called congenital central hypoventilation syndrome. This is extremely rare. Many pulmonologists will actually spend their entire career trying to find this. Yes?
And we had a question, I'm sorry to interrupt you, in the chat about, can you help us explain the switch? You said all of us said it was a big switch for you?
Yeah, so by definition with colic, what happens is it's typically a switch on, switch off for some unknown reason, and we don't know. Kids will just cry, and they will cry, and they will cry all night long. My parents, so the grandparents would come over and go, wow, your child is amazing. And of course my child was amazing. This was Sophia. It's interesting that my last child was the one with colic. And I say that as a joke, but she cried, I nonstop for hours on end. And my wife and I would take turns holding her. My wife and I would take turns just making sure she was okay. And then literally one day, she stopped crying. It was a switch. It's a phase. It will go away, but it took probably a good 2 to 3 months. It didn't matter what we did. Obviously, I work at Mercy. I even had one of the GI doctors take a look because I was like, this can't be colic. It's colic. So colic is pretty impressive. And so, again, there are other things interrupting sleep. And for my daughter, that was definitely something that was interrupting her sleep. So I hope that answered the question. So what I'd like to do is kind of talk about putting this all together. So let's explore some toddler sleep. So this is ages 1 to 3. And if you remember our diagram or our PowerPoint, they're still sleeping half their life. So 12 to 14 hours a day is typically the norm. Are they having a nap? Most definitely. These kids definitely need to take a nap. It usually goes from 2 to 1, but over 90% of the 3-year-olds are still taking a nap a day. What I do as a pediatrician is I'm looking at those developmental skills, and a lot of those developmental skills can actually lead to why a parent might be having trouble. So you have an increase in locomotion. You put them out of the crib to the toddler bed. Well, lo and behold, they get out of their bed to come see mom and dad. So there's increased locomotion, a huge increase in cognitive and verbal ability. You have a very vivid imagination, and there can be some separation anxiety. So you have this combination of separation anxiety to the want or need for independence. So the 2 most common issues I see is something called sleep onset association and limit setting or bedtime resistance. And so let me kind of go through some of these for you. And again, this is John and this is Sophia. They're 15 and 14 now. So what I will say as parents is enjoy it. Literally, you blink and in 5 years, they're 5 years older. I mean, I'll blink and in 5 years, I may be an empty nester. So it's unbelievable how quickly and how much fun this could be. So with sleep onset association, the idea is we all wake up at night, but can you go back to sleep? So there's not one person, as Jonathan knows on sleep studies, that has an arousal index of 0. We're all waking up. But with sleep onset associations, there are learned conditions that promote the onset of sleep. So what are common sleep onset associations? Co-sleeping is probably the most common. Feeding or nursing, especially with those little babies. Some parents will rock, sing, or soothe to sleep. So what's happening is the parent helping their child go to sleep is actually developing learned conditions in which the child wakes up in the middle of the night and the child doesn't know what to do. So what do? They go back to the parent and they say, hey, help me out. Help me go back to sleep. So the treatment options is to really acknowledge this sleep onset association and explain the consequence. You do not have to get an overnight sleep study for this. Developing good sleep hygiene, instituting a good sleep schedule. But really the key, I'll be honest with you, is putting them down drowsy but awake. They need to learn how to fall asleep on their own. You can have a bedtime routine and let them understand the rules of the bedtime routine. You can have transitional objects. Sometimes just giving the child a new look or new environment can help as well. And then the idea of extinction versus graduated extinction is some of the treatment plans. So extinction, believe it or not, is called crying it out. And it's exactly what you think. You close the door, you don't open the doors till 7 a.m. And it's very difficult for the parent, but eventually the child will go to sleep. The Ferber method, or what we call graduated extinction, is actually checking on the child in timed intervals. So you go in 5 minutes times 3, 15 minutes times 3, 30 minutes times 3. But each encounter has to be brief and boring, and you don't give in to the child. You don't sleep with him again. But eventually, with time, the child will understand, well, my mom and dad are around. They're not giving in to me, and they learn how to fall asleep on their own. So extinction and graduated extinction are really the only two best behavioral strategies for sleep onset association disorder in this age group. Older kids, we can do other things like token systems and things like that. But you can imagine for a 1 to 3-year-old, these are our best bet. The other more common childhood insomnia is what I call limit setting disorder or bedtime resistance. And it's that idea of the development of independence and increased cognitive and verbal ability. But what happens is the parent, I hate to say it, has an inability to enforce bedtime, either naps or nighttime, and it really results in refusal to go to bed. This too is a learned behavior, and it results in sleep delay and not getting that adequate amount of sleep. I call these curtain calls. If you have a child that says, give me one more book, give me one more hug, give me one more sip of water. So it's very common, and my children have done it. Even in adolescence, they do it. They do it for different reasons. But it's really these curtain calls, negotiations. You're just negotiating constantly. And what you really need to do is understand the situation and kind of have firm rules that you can follow. So I hate to say it, this is one of our problems again as well. So these are, it's a lack of firm rules, and it's allowing the child to escalate their behaviors and their curtain calls to where now the parent is actually just going through them. They're running the situation, and the parents are just responding instead of controlling. Is a sleep study needed? No, it's rarely needed. Maybe if you have other issues going on, do you have like a restless child and there's restless leg syndrome? Do you have other medical issues such as reflux? Do you have side effects from medications? I mean, I'm a pulmonologist. If your asthma is not under control and you're dosing your child with boatloads of albuterol at nighttime, you can imagine he may not be sleeping because he is jittery and his heart is racing. And so there's side effects as well. Obviously, the last one would be there's abuse in the home, either an older sibling or something else going on. So non-accidental trauma or child abuse is obviously a very rare cause, but it's something the provider we always think about. We want to make sure that the child is safe. So what is the treatment? Is really focusing on good sleep hygiene, setting a firm bedtime routine and schedule. And you have to have firm and clear rules that you can execute. If you're unable to follow your own rules, children are smart and they're going to take advantage and they're going to manipulate this. But you have to ignore complaints. You have to ignore curtain calls. And I'm a big fan of avoiding punishment and using more positive reinforcement. A lot of times I get older children with limit setting issues, and I use something called a bedtime pass or a token system. And what that enables the child to do is kind of have a positive reinforcement or maybe a reward if they follow the rules. Now, you can't tell them to sleep. Nobody can force a child to go to sleep, but they can follow the rules in hoping that they can fall asleep, if that makes sense. So next we'll go to kind of the next group, which is the preschoolers and the middle childhood. So we're losing that nap. That's a big change. Remember, a lot of these kids count on the nap, but at age 3, 90% have a nap. By age 5, maybe only 25% are needing that nap. So I get a lot of referrals from 4 to 5-year-olds saying, my child doesn't nap anymore. What's wrong? I hate to say it, that can be physiologically normal. Remember, the amount of sleep and how they sleep has to be individualized. The one thing I love about this age group is there's a developmental explosion all throughout the elements of development. And so we'll talk about some of those parasomnias that I mentioned, the sleep tears, the sleepwalking, the sleep talking, and we'll go into some other ideas as well. So if anyone's experienced a sleep tear, or I should better say, have they had a child experience a sleep tear, they're pretty frightening, especially the first one. The second one, the third one, the 18th one is not. Typical age is, again, the younger patient. It often happens in the first part of the night. And the reason for that is that's when the bulk of that non-REM sleep. So when you have a child that goes to bed and within an hour or two, they have these over dramatic, unbelievable events. They're quite dramatic. They're quite disturbing. There's a lot of intense autonomic issues. They can be crying. They can be screaming. They're typically not consolable. So that's probably a difference from a nightmare or a nighttime fear. They're not consolable. So you can hug them all you want, but they're actually sleeping and they don't remember the episode. You can ask them the next day, hey, why were you screaming and yelling in the middle of the night? They'll go, Dad, I have no idea what you're talking about. So these are very common. As you know, they're almost a passage of childhood. And really, education and reassurance is the best key. Some people talk about urban legends of waking them up from sleep tears and doing all these other things. I don't think you have to do any of that, I'll be honest with you, because I think they will pass. Very rarely do I see chronic sleep tears, or at least frequent sleep tears, in my older children or my adolescents, because remember, the non-REM sleep is going to change and there's going to be adjustments in some of their sleep as well. Sleepwalking is also a parasomnia. And the one thing that I want to break out is look for that family history. Because if you have one parent that's had some parasomnias, whether that's sleepwalking, sleep talking, night tears, it's very heritable, meaning that child will get it. Usually it's almost heritable to about 50%. If both parents have had it, then those kids are probably going to have some of these parasomnias. But as I said, it's almost a passage of childhood. 15 to 40% will have one episode. About 5% will have multiple episodes. They can continue into childhood, but that is pretty rare. It's out of slow wave sleep. And probably the most important thing I try to tell families is go through your house just like you did when your child was 1 or 2, and try to protect the home in how a 2 or 4 or 6-year-old would walk throughout the home. So look at safety measures. If you have open doors, if you have open stairs, try to have doors that might block that. Put locks way up high so they can't get to the door. Really basic safety measures and safety features are important. Now, what can make sleepwalking worse is any type of poor sleep. Medical sleep issues can make things worse. But typically, sleepwalking and sleep talking and things like that will resolve with time, and keeping the child safe is the most important. Nighttime fears. So nighttime fears are different. And so what's the difference between a nightmare or a nighttime fear? A nightmare actually occurs in REM sleep, and it's a frightening dream that wakes the child at night. And the child will say, I'm dreaming of X, I'm dreaming of Y, I'm dreaming something. And nightmares are normal. What's a nighttime fear? A nighttime fear is often an age or developmentally related issue. Toddlers obviously fear parental separation. Preschoolers, the big one is monsters, dark or loud noises. School-age children, again, monsters and dark is always probably 1 or 2. But the school-age kids may be worried about bullies at school, natural disasters, things like that. So I think one of the important aspects is when they're looking at the nighttime fears is making sure it's age and developmentally appropriate. If you have a real young child with a very abnormal fear, there may be something abnormal going on in the home, or maybe he or she has older siblings, sadly letting him watch YouTube videos that are scary or clown videos or something like that. So usually asking a few separate questions, you can kind of get to it. But nighttime fears, I hate to say it, are age and developmentally they're normal. So what do? I think education and acknowledging the fear and understand that this is appropriate for pediatrics. Obviously, you're ruling out any type of true medical or social issue. You can develop creative solutions for your child. You can talk about monster spray and kind of spraying the room if you're worried about a monster. Night lights always help. Play phones or pagers or blowing away a lion or blowing away a monster. That can always be important as well to the little kids. I think it is important to discuss the child's fear, but I wouldn't do it in the middle of the night. I would say, hey, let's talk about it tomorrow. But when you say that, you have to do it. So you have to sit down at the dinner table, maybe around lunchtime, maybe around dinner, and maybe change that fear into something that could be fun. If anyone's ever seen the movie Monsters, Inc., that's exactly what Monsters, Inc. is. If you've seen that movie, these monsters that get their energy source from kids crying, but at the end of the movie, you realize these monsters are more scared of the kids, and laughter actually gives more energy than crying or screaming combined. So Monsters, Inc. is kind of that idea when you actually change the outlook or change the idea of a perceived fear or perceived problem, it actually can go a long way. So I think this is one of the most important things you can do as a parent, because again, fears are normal. If you blow them off and if you just say, you're crazy, remember these kids don't have the cognitive ability or the life lessons that we have. They're really scared of some of these things. So kind of making it fun and kind of making it, maybe that thing is really a buddy. And, there's multiple ways to do it, because my worry is if you don't address the fears, they're going to develop bad habits such as limit setting, bedtime resistance, and then you're going to be sleeping with your child and you're going to develop sleep onset association. So nighttime fears are really, really important in this age group. So I'm at about 15 minutes. I'm at about 5:45. This is one of my favorites because obviously as a sleep pulmonologist, I see a lot of what we call sleep disordered breathing or sleep apnea. It's probably the number one referral that I get. And the American Academy of Pediatrics, really in 2002, so only 20 years ago, started addressing that, hey, maybe sleep in pediatrics is important. Funny enough, kids have been sleeping for a long, long time. And that's why pediatric sleep is really in its infancy. We're learning about pediatric sleep. And being a provider, I think this is one of the things that you really should be on the lookout. So what the report said now about 18 years ago said all children should be screened for snoring, which obviously would be turbulent breathing. High-risk infants, which we already talked about, children with craniofacial issues, genetic issues, probably should be referred to a specialist. And really the gold standard is a sleep study. I get reports of videos all the time. I get, overnight oximetries, things like that, but really getting a sleep study that can dive into some of the physiology is really, really important. So reported studies have shown that clinical history alone is really inadequate to distinguish between a noisy breather and what we call sleep disordered breathing. So a lot of times in pediatric sleep apnea, you have these massive tonsils blocking the back of the airway. This is the uvula that hangs down. So we have tonsils that are touching each other. And you can imagine when you go to sleep, not only do you snore, but you obstruct your breathing. So you can have a true obstructive apnea, or you can have a lot of what we call obstructive hypopneas. which is not completely stopping your breathing, but pausing your breathing enough to result maybe in a desaturation or an arousal. And this is my daughter. So I'm hoping you guys can hear this. Oh. Can you guys hear this?
No, John, we can't.
You
I
can't.
was gonna say, I think Dr. Spivey, when you go to share your screen, there's a little checkbox that you have to mark if you want to share video, audio, something like that.
Oh, really?
You can unshare and then share again, and you'll get the pop-up box again.
Well,
Or
I
not.
think for lack of time. So what you're seeing is this is my daughter. She's snoring. Her nose is flaring. She's actually
Yeah, a really good sign. A really good sign there was you can see the chest cavity in the wall.
Yeah. So
Labored
So look at
breathing
her-
going on.
look at her neck. Her
Yeah.
neck is pulling in. She's retracting. Her nose is flaring. She's sweating back here. I don't know if you can see her hair's sweating. She gasped right there. But it's not only snoring, it's gasping for breathing. It's pausing her breathing. And funny enough, I read sleep studies for a living. And I told my wife, I said, you know, our daughter sleeps worse than these kids that I actually read sleep studies on. And my partner, Dr. Chikang, saw her, got a sleep study here at Mercy and got her tonsils out. So she had massive tonsils. And unfortunately, I guess you can't hear the video, but this is her after surgery. She's fine. She's fine. You can't hear a sound. She's not working hard to breathe. She's
That's
not
a lot more a lot more peaceful.
Yeah. So sleep apnea is probably the more common thing you'll see. And this is a medical problem for sleep. And Jonathan will talk more about this, about what is a sleep study and what we're measuring. Obviously, it's a very physiologic and a very fun way to look for sleep disordered breathing. And I'll let him kind of talk more about that. But one of the things people always ask me is, well, kids and adults are the same, and they're not the same. So you can see with children and adults, now the obese child, funny enough, is trending more towards the adult because of the physiology of the obesity. But the child, remember, their peak age is probably with increases in their tonsil size and their adenoidal size. It's equal male and female. They often have these obstructive hypopneas, where they can have obstructive sleep apnea. And obviously taking out the tonsils is probably the best thing. But these children are typically not obese. They have something in the back blocking their airway, where the obese child is looking more like the adult. And that's something that our adolescents and things like that we see. So these are, again, those high-risk babies that probably should see a specialist. Children with Down syndrome, Prader-Willi, achondroplasia, morbid obesity. Here's my peer Roban's friend that have a cranial facial issue, these craniosynostosis, sickle cell disease. Funny enough, when I was at Children's, I was fortunate enough to do some research with sickle cell in sleep. That's actually what got my passion in sleep medicine, is looking at these children with sickle cell and even cerebral palsy, neuromuscular disorders, things like that as well. So I'm going to go pretty quickly through this, but these are kind of our adolescent group. And as I mentioned before, everything in pediatrics is a phase. So what's going on with the adolescents? So adolescents should get, what did we talk about? 9.25 hours of sleep, but in reality, they may be getting less than 7. And why is that? Because they're balancing school, extracurricular activities, social activities, work activities result in their accumulation of sleep debt. The number one question I like to ask for inefficient sleep is, what time do you wake in on the weekends if you have no responsibility? And a lot of times kids will sleep until noon or 2 or 4 o'clock, and that's a lot of sleep debt putting on the shoulders of our adolescents. So one of the things I want you to look at is the delayed sleep phase syndrome and early start time. So remember, with our sleep-wake pattern, you have that 10-year-old going to bed at 8, and then we don't go to bed at 8. Well, that's exactly what's happening to our adolescents. During puberty, there's actually a circadian phenomenon that results in a later shift time. So these teenagers that used to go to bed at 8 or 9 are now going to bed at 9 or 10 or 10 and 11. And what do we do as parents? We yell at them. We go to bed, go to bed, go to bed. Guess what? It's not totally their fault. My adolescents go to bed later than me sometimes, not all the time. But they have a normal physiological based sleep delay in 2 hours. Many of these kids, I hate to say, it's pushed even further because of nighttime electronics, Xbox at 4 o'clock in the morning. And now these so-called night owls can't keep up with daytime demands, and their sleep onset becomes later and later. They can't wake up in the morning. They have daytime fatigue, and they're falling asleep at an earlier bedtime. So the goal is to kind of shift them back, but it's more than just shifting them back. This is a true circadian rhythm issue. Sometimes you have to actually get bright light exposure. Sometimes appropriately placed melatonin will help. But really the success of the teenager is this highly motivated teenager that wants to make changes. If the teenager doesn't want to make changes, it's never going to happen. But the best thing is, it's instead of worrying about when they go to sleep, worry about when they wake up. Because when you wake up, that sets your circadian rhythm, and it allows their late bedtime to be slowly advanced back to maybe midnight, 11, or 10 p.m. So delayed sleep phase is probably the most common issue I see in my teenagers. And this is what I'll end on, is this is the American Academy of Pediatrics trying to change some of our school times for adolescents. Because isn't it interesting that our little kids go to bed, our little babies go to bed and they wake up early, but our adolescents stay up much of the night and they have trouble waking up in the morning. But what does your high school do? My high school, which was Melville High School, started class, I think at 7:15 or 7:20 in the morning. I actually played baseball, and I would have a 6 a.m. baseball practice before school. You can imagine, as an adolescent, I didn't get much sleep. And so the American Academy of Pediatrics is trying to better coordinate the adolescent's biology of sleep into the high school program. So remember, these teenagers should be getting 8 to 10 hours of sleep, but many of us, I hate to say it, we're less than 7 hours. So this tired teenager, what happens is they're really unable to utilize the opportunities of our educational system. I can't imagine, what these kids can go through, because we give them Chromebooks, we give them all these opportunities. But if you're falling asleep in class, we're just not able to coordinate, this tired teenager. This can lead to cognitive defects, impairment in attention and memory, and it really results in lower academic achievement. But it's not just your ability to perform. This is a health and safety issue. There can be drowsy driving. And one of the other issues with American Academy of Pediatrics is this use of energy drinks and monster drinks and everything of these countermeasures to try to keep kids up. I don't know about you, but when I was a kid, I didn't drink coffee. But now it's almost all these kids are coming in tired, and they have a Starbucks in their hand, and they're drinking 2 or 3 coffees, or they're drinking Monster or energy drinks to stay awake. So we have to we have to go back to what we know works, which is just good old-fashioned sleep. This can lead to poor impulse control and self-regulation. It can lead to obesity as well. And I think, as you know, if you don't have good sleep, or if you're sleep depressed, study after study after study shows it can lead to mood issues such as anxiety and depression. So this is kind of a funny report 5 years ago, and it talked about, well, the American Academy of Pediatrics recommends starting school after 8:30. So how are we doing as a nation? And you can see 75 to 100%, which is in the blue, they typically start their high school before 8:30. So are we listening? We are not listening. So this is actually one of the reasons why I like to speak to parents. I love to speak to educators, because really what the American Academy of Pediatrics is saying, we should start high school after 8:30. This is middle and high school, and it gives the teenagers an opportunity to reach that 8.5, 9 hours of sleep. I also try to educate the adolescent themselves and the parents about optimal sleep and to match their physiological needs. This should be done in well child checks. This should be eliminating any type of electronics at nighttime. And again, not using caffeine or energy drinks to keep them awake during the day. And this is from the CDC. You can pull this up as well. It says 5 out of 6 middle and high schools start their day before 8:30. Teenagers need at least 8 hours. I would go as far as 9 hours, but only 2 out of 3 high school students or 2 out of 3 are sleeping less than 8 hours. So adolescents that don't get enough sleep may be overweight. They don't get enough physical activity. They're not feeling well. They often have self-control issues, as we mentioned, and they may not be making the most of our educational system. So in conclusion, I hope you guys learned today that kids are not tiny adults. They have different sleep architecture, and they have different sleep needs. Sleep also is not a passive process. It's very dynamic and it's very active, using childhood development and learned behaviors. So look at that goodness of fit model. That's something that I think will help all of us with our children. And remember, early childhood problems could be related to parental expectations or child rearing techniques. And obviously, if you have problems, let us know. So this is me, and this is my partner, Dr. Chu Kang, and we obviously see lots of folks for sleep medicine issues. We're also pulmonologists as well, but I am going to stop sharing, and hopefully you can see me, and I'll open up for any questions that you may have. So one question on the chat right here, it looks like the thoughts on sound machines. So I get this quite a bit. As a purist, I'm a big fan of less is more. I think when kids have problems with their sleep, what they do is they do more and more and more and more. If you use a sound machine, what I would highly recommend is make sure that that sound machine is very mundane and it produces kind of a repeated sound. It's like a creak or a white noise, things like that. Because if you actually have a radio in the background or music in the background, believe it or not, when you're sleeping and different sounds and different things are being noticed, that can actually cause you to wake up. But I think I'm a big fan. If you can get away without any sound machines, what it ends up developing, I think, is a form of sleep onset association, because you start associating your sleep with sound machines. But again, you could do a lot worse, that's for sure. And even my kids at one point had some sound machines where I think they had crickets or grasshoppers or a creak or something like that. But as long as it's a very mundane sound. Yep. Yeah, I can hear. Can you guys hear me? Okay.
Yes.
Yes. Okay. So you guys can do the chat or any other questions. Hopefully
Yeah.
that was valuable. I know I'm going quick because, to be honest, I could take one of that group and I could take an entire hour. I mean, I've given an entire lecture, honestly, on sleep disordered breathing or sleep apnea. So, but I wanted to kind of give you kind of a brief introduction into pediatric sleep. And also, as a parent, what I typically tell folks is it really truly is a phase. The problems that you'll see from 1 to 3 is going to be different from 4 to 8. And now my adolescents have different sleep issues. I mean, funny enough, I can't even go into my kids' room. I try to go in and tuck them in and all that. And they point to the door and they go, "Get out of here, Dad." And so, all the angst that we had as parents about sleep and all this stuff, it's a phase. So really try to enjoy the moment. Easier said than done, but enjoy the moment and really try to just give your child an optimal ability to sleep. But as you know, if someone says go to sleep, you can't force anybody to go to sleep, but you can give them the right tools and the right ability. So I have another one here. It says, my 5-year-old wakes up and has trouble falling back asleep. She will stay up for hours laying quietly in the bed. Does she just have to learn to go back to sleep, or is it a sign we've tried everything? So yeah, I guess you have to make sure that there's nothing disrupting her sleep. So what I would recommend is watching her while she's sleeping, making sure that her legs aren't hurting or she's not having motor restlessness. There is an entity called restless leg syndrome that could definitely affect kids at this age group. They kick their legs, they just feel uncomfortable, they just can't go to sleep. Sleep apnea, usually kids can go back to sleep with sleep apnea, but make sure that she's not snoring at night, stopping breathing at night, making sure she's not having any pain. But I hate to say it, if she's just laying there for hours, I know this sounds funny, but I would have her get out of her bed. I would have her get out of her bed for about, if she can't fall asleep in 20 to 30 minutes, maybe lay on the floor. Don't do electronics, don't do video games, don't do anything that's going to develop bad habits, but maybe, look at books. She may not be reading a whole lot, but look at books and, that can kind of help her unwind a little bit, because honestly, just laying in bed frustrated does not induce good sleep. You actually want to get out of bed and then give it another opportunity. Like I said, it's easier said than done. But you could kind of ask why she's having trouble falling back asleep. So melatonin is a question that I get a lot, and I think melatonin is a fantastic supplement. Melatonin works with the ability to fall asleep, but melatonin does not help maintain sleep. So melatonin is released right at bedtime, typically with dim light. So melatonin is only used, or typically only used, to help with what we call sleep onset insomnia. You're having trouble falling asleep. But melatonin doesn't work if you're not staying asleep or if you're having nighttime awakenings, things like that. Most people will actually start with melatonin before they would go to anything else. But I try to tell folks there are no FDA-approved medications for pediatrics and insomnia. So it's always best to start with behavioral modifications, understanding what the problem is before going to medications. So after this talk, you should Google the FDA-approved medications for insomnia and pediatrics, and you're going to get 0. But we all start with medications except pulmonary providers. So if you see me, have I prescribed melatonin? Of course. Have I prescribed things? But I usually try not to start with that, if that makes sense. I try to address issues, nighttime fears, all these other things. How long, so this is a good one. How long does it take to break sleep onset associations? Well, That's a tough one because how long have they been going on for? And how stubborn or hard-headed is your child? So everybody is different. So, I mean, so if this is a child that hasn't fallen asleep on his own in 3 months, that's an easy one. If you've learned this behavior for 4.5 years, guess what? It's going to be hard. So it depends on the kind of the flexibility of the child and how long it's been going on for. But I will tell you, even the most stubborn of kids, they can break. Sometimes you have to use even other behavioral associations if they're old enough. Like I said, I love the idea of a bedtime pass. You give them like a quarter or a token or a pass, and you tell them to take this and put it under their pillow. And if they sleep all night, they can take that token and they can give it to you the next morning for a special prize. Now that special prize better be worth it or they're not going to do it. But it can be a nice prize. You don't have to buy them anything, but it's a special prize. The other idea of a token is if they do use that token and they give it to you in the middle of the night, you have no guilt. It's a part of the process. You tuck them back in and you say, hey, we'll try again tomorrow. But you'd be surprised how smart and how, if the child can be somewhat goal-oriented, the token system or the bedtime pass works better for our older kids like our middle schoolers. All these kids like electronics, all these kids. So if they have a carrot that can kind of motivate them, I would use the Ferber system along with kind of the token system, and you'd be surprised. Sleep onset association can break. Let me see some other ones here. What treatment options are there for restless legs in children? So typically the basic treatment options are wondering about any type of nutritional deficiencies. So the biggest one is probably iron or iron deficiency. And we often get a ferritin or an iron level. There have also been some recent studies over the last 6 months to a year to look at vitamin D. So what I typically recommend is supplementing any type of nutritional issue first. There are other medications that you can try. Probably the most common prescribed medicine is a medicine called gabapentin. But as a pediatric person, I'm always trying to go to the nutritional route. I try to do behavioral issues, things like that before going to gabapentin. But like I said, I have prescribed gabapentin. The dopamine agonists are also used in adult and pediatric restless legs. But for that, you have to really be suffering. I'll be honest with you. You have to have a sleep study. You have to sleep study showing me all these restless legs with arousals. I have to have proof before I'm going to a more stronger medication than that. But yeah, there are really good therapies for restless legs. So next question is, having to get a TNA, be a breathing struggles, be hereditary, and at what age should the tonsils develop enough to be apparent? So probably big tonsils are somewhat heritable. I don't think it's 1-to-1. But they probably start growing around ages 2 to 3. They probably get largest in size, I would say, from 4 to 6 to 4 to 7. But as you know, there are teenagers that still have big tonsils, things like that. But it's really those toddlers and early school age kids. And to be honest, you don't have to be a doctor to look. Just look in the back of their throat. You can see big tonsils. Look for nighttime snoring. Look for any type of apneic pauses. So your child's actually stopping breathing. They're gasping at night. They often seem like they're working hard to breathe. And sorry, my video didn't have sound, but yeah, poor Sophia is just snoring up a storm. And then the take-home message is after surgery, you can't even hear her. It's pretty cool. So you took away the obstruction. My daughter obviously you know, in that picture, you could tell she's not a heavy child. She's not an obese child. She doesn't have any, you know, craniofacial issues or anything, but she had tonsils that were touching. And yeah, it's in many times in pediatrics, it's curative. Now for the older patients or patients with other issues, a tonsillectomy, adenoidectomy may or may not be curative, but for Sophia, it was. Well, listen, how about if I stop for today, because Jonathan, I'm actually excited to hear your talk as well.
Oh, man, I was excited listening to you.
Yeah, so why don't, is that okay with everybody? And yeah, I want to kind of see Jonathan's talk here. So I'm excited, but yeah, thanks for letting me speak today. And you guys can, you know, get a hold of me or try to get a hold of me if you have further questions or things like that. I'm always available.
Yeah.
Thanks so much,
really
John.
quick,
Appreciate it.
Yeah, really quick on the restless leg syndrome. Another approach has been, you know, known that if the child's not active prior to going, you know, hasn't been active during the day, you're going to see a lot more of that, right, Dr. Spivey? You're going to see almost getting it out while they're trying to lay in bed.
You know, it's funny that you said that, because in the middle of COVID, in the middle of virtual school, you know, I think all of our kids probably aren't as active as they were. So yeah, I mean, it's that fine line. You got to have some activity. You got to kind of, you know, get those crazy legs out, especially, I'll be honest, especially with boys. I think boys need to move. I think boys need exercise even more than girls. And I'm not saying that the girls don't need exercise, but Jonathan, no, I completely agree. Try to maximize the natural aspects to induce good sleep. And then you look for nutritional issues. Then that's when we sometimes send them off to a sleep study, or we do special types of medications. But we try to do those others first.
Well, that was great. Thank you, Dr. Spivey. I appreciate it. All right, well, we'll get started with mine. Mine is more talk than presentation, so that was really nice. That was really well put together. So I'm going to take you guys to my screen. Let's Can everybody see mine? Am I muted?
Yes, sure can.
Okay. So my name is Jonathan Charpentier. I am a registered sleep technologist at Mercy Hospital. I am the team lead here, amongst other things, it feels like. But my job here is to make sure that the patient, all things are needed for that patient to have the utmost up-to-date sleep study possible, and to make sure my technologists have all that material they need to run that kind of study, and to train. Part of my job is to precept and train the technologists. I also work with the respiratory therapist students that come from Mizzou. They do their clinicals with us here at Mercy, and I get to work with them. So yeah, that's part of what I do. Other parts are running, just making sure everybody is happy. Management, physicians, patients, and the technologists. So, again, my name is Jonathan. I'm the team lead. That is my email and that is my phone number. So if anybody has any questions at any time, that maybe didn't come up tonight, please feel free to call me or send me an email. I will respond. So our sleep medicine department, we have been here in this building for around 7 years. We were originally a pediatric sleep lab, where it was just peds for a while. Dr. Spivey, correct me if I'm wrong, but I wasn't here at the time, but I was told that it was 2 rooms and it was pediatric. And Dr. Chu Kang, Dr. Spivey's partner, was a big part of that. He's still a big part of what we do here, but he was a big part of getting that going and getting that up and running.
Most definitely. Most definitely.
Yeah, yeah. And this is one of our rooms. This is one of our pediatric rooms. We have 12 rooms here. We have 8 that are more on the adult side. And then we have 2 that look like what you're seeing here, and another 2 that accommodate what you might have seen at other hospitals, which is like the fold-out couch and things like that. So we try to make sure that if you're coming to visit, this is one of the rooms you're in. What you don't see, and I'm gonna have to say it, Dr. Spivey, is right over here. Can everybody see my mouse? Can you see that mouse there?
We can see it, Jonathan.
Okay.
Yes,
So
we can.
right over here, we do have a TV. Okay. But as sleep technologists, we understand the importance of seeing how that child or how that patient, regardless of age, is able to fall asleep without what they consider assistance or help. Everybody says it's help, but if you take it away, and start without it, you'd be surprised how many people actually fall asleep. Now, do they believe they're falling asleep? Most likely not, because what happens when we see a patient or they get to the sleep lab, I'd say a good 75, 80% of those patients do have a sleep disorder. It's almost like if you made it this far, there's a high probability we're going to see something. And with that said, that means as that person's falling asleep, they're only falling asleep and getting into the light stages of sleep, which you're still conscious of your surroundings. As an adult, I'll be the first to say I've been on the couch with my kids, and I will do that whole, and I'll wake up and look around, and Maddie or Gabriel will be like, "Dad, you're sleeping," So, and I didn't feel like I was sleeping. So, we do try to start without that TV. We do understand that it is sometimes do or die. Like patients will get pretty frustrated or upset. So what I did as a technologist, I asked my technologists to do is I asked them to set the timer. Or to start without it, if there's 30, 45 minutes of not falling asleep, then we introduce it and we set the timer on that. Preferably for 30 minutes, because most likely that patient's going to fall asleep. Very rarely, it's probably less than 5% people we see have true insomnia, especially pediatrics. We don't see that quite often, but this is one of the rooms. So mom and dad will be here, or the guardian, and then the pediatric patient would be here. Of course, we have the crib that we would replace for this bed. Some of what you're seeing here is the monitoring system. All these leads and wires will go into this little box, and then through the network finds its way to the control room where the technician would be staying all night monitoring that patient. This is the sleep medicine team. I'll make sure that Adele, you get this PowerPoint, but these are the links to online to see our team here, this pediatric sleep medicine team. And it goes over a few things. Dr. Spivey, sorry, I had to put Francis in there. That's beautiful. I didn't know that. That was first for me. So this is his link where you can see a video and he talks about his passion, which is great. And then we have Dr. Chu Kang, who is his partner. And the team does work with neurologists, because sometimes we do full EEGs on top of these other parameters that we look at, like breathing and legs and limbs, like Dr. Spivey talked about with restless legs and stuff. So the neurologist will review that data if it's a full EEG for the pulmonologist or the ENT that might have ordered the study, or the primary, the pediatrician. Another big thing that Mercy is really trying to work toward and work a lot with is having behavioral therapists involved, which is great. We see a lot of patients with ADHD, or we see a lot of patients, with autism or, just behavioral concerns going on. And these most of the time are, can be contributed or are a result of sleep disorders. The registered polysomnographic technologist, which is what I am, and most people don't know this, but there is a board, the American Academy of Sleep Medicine and the Board of Registered Polysomnograph Technologists, where you actually will sit for your exam, and it's over 250 questions. It talks about what that technologist needs to know a little bit about, not be a complete expert on it, but pretty much all your specialties. You have pulmonary, cardiology, neurology, you have, rheumatology, you have, I don't know what I'm missing. Oh, psychology. That's another big one. Well, depression, anxiety is a big problem with people that suffer from sleep disturbances. And then on top of that, you have to understand sleep and be able to take what you've recorded and to document what stage of sleep that patient's in. If there's an arousal, you highlight that arousal. You also highlight any type of sleep disorder that happened in this 30 seconds. I mean, we go from 32nd page to 32nd page, and we do what's called scoring it. That happens through the night, and then it goes over with a fine-tooth comb the next day, which I'll touch on a little bit later. So all the technologists here at Mercy Sleep Medicine in St. Louis, they are credentialed. We do have over 70 years. I did this number last week, and it's really cool. I mean, we have 70 years of combined experience in pediatric sleep medicine, which I'm very, very proud of, which is, really cool. And you don't find that in a lot of places. All the technologists, like I said, I'm the preceptor here at Mercy, and I've been doing it for a while. All the technologists start with adult patients. If they have a history of working with pediatric patients, then we tend to move them in a little quicker to the pediatric population. But it is, like Dr. Spivey said, they're not many adults. They're their own thing, and you've got to approach it that way. So that's part of that training process too, is having that technologist recognize that. And also the different things you might have to do compared to that adult patient. So the technician starts with the adult here, and then we move them into the pediatrics because it is going to, it takes more out of a person, more out of a technologist at times. Like sometimes it can be really easy with a ped, and sometimes you are, working with them a little bit more than you would an adult. So it does take a special person that has an interest in it, one, and it does take some time to develop them into working with peds. And then the other thing is all of us, everyone works here as a parent. So we've all been blessed with that. So understanding, a child and their mindset. Most of us, I think Tina is the only one that she probably has the youngest child, which he is 8. Everybody else is probably over their teens or above. Well, I have Gabe, so he's 11. So, but we've all been there. We know how the baby is, at least our baby, and then we know gradually getting older, like Dr. Spivey said, it's different. There's different groups. And we are passionate. I mean, there's not one person that works here truly isn't passionate about helping, no matter what age, but really that the pediatric patient, we talk about it a lot. The idea is to make sure we get to this population as soon as possible, because we see 35-year-old, patients, 45, 50, 60. And like Dr. Spivey said, this is fairly new in the world of medicine. So we see patients that are 50, 60, that most likely was that 2 to 5-year-old that's been experiencing this problem their whole life, and the sad part about that is they usually come in pretty beat up medically, or health wise. And luckily we can help them at that point, but we could, the idea is to not get there. And we're again blessed to be able to provide those services here at Mercy. So we're passionate about that. And we also understand that that pediatric patient, by improving that patient's quality of life, it's going to improve the family as well, the household, because it does. It affects everybody in that house. Same with the adult patient, the family, if somebody's tired, everybody else is going to recognize it. So the polysomnography, it just means it's Greek for many sleep graphs. Their sensors are strategically applied to different parts of the body. We look at the brainwave activity. So we'll have electrodes that go on the scalp that just help us distinguish between sleep and wakefulness, and normative or abnormal brain activity at times. And like I said earlier, sometimes we do these full EEGs to help rule out seizures at night or during sleep. We do EKG monitoring. So we'll have 2 leads underneath the collarbone of the child, and then we'll have one down on the left rib cage. So we can monitor the heart and evaluate that rhythm and make sure there's no what are called arrhythmias. There's no problems with that. Or issues there. So those can be addressed as soon as possible also. We look at the respiratory or the breathing efforts. So we have a belt that goes on what's called the thoracic cavity or the chest here to measure that movement. And then we have one that goes around the abdomen that measures the diaphragmic efforts, how the diaphragm is helping move everything. We also look at muscle activity in a couple spots. We look at that on the chin. We'll place one right on the tip of the chin and 2 underneath here. Sometimes those can differ depending on what's going on with the child. We can put them off to the side, but those help us also determine sleep. The more restorative stages of sleep that a person gets into, the more this muscle tone decreases. So it's very important for us to see that. Also helps to see gritting or grinding of the teeth, which is cannot just damage the teeth, but they can also produce arousals and cause arousals through the night. We also look at the legs. That way we can rule out restless leg syndrome, like Dr. Spivey had spoken about, or what's called periodic limb movements. Not as common in children, but we do see them. It's where a person will periodically kick and twitch. And it can be benign to where it's not interrupting or fragmenting somebody's sleep, or it can be very, very disruptive to that person's sleep. So we look for that. Oh, also, just going back here, sometimes there are different types of studies where we will add leads. So we have that full EEG for seizures on top of these other leads. And then we have what's called a REM behavior sleep study, which helps us determine if a person's acting out their dreams physically. So we'd add we'd have this normal sleep study and add some to the arms to see, moving of the arms and stuff. So part of that polysomnography, we are looking at the carbon dioxide in the body. We want to make sure that is properly maintained and at the right levels. We also look at the oxygen level. We want to make sure that there's no what's called hypoxemia, where the oxygen level is dropping, dipping, and if we do see it, why? So we look at these respiratory channels and tend to see if it's like apnea that's causing that. We do an audio recording also. So there's a monitor in the room where you can talk to the technician, or the technician needs to talk to the patient. They can through the control room. And it also just records that audio. And of course we have video, because video is necessary to help diagnose certain sleep disorders for the physician. REM behavior disorder, we can see physical parameters that help the diagnosis, but to see the acting out of the dream and things like that and have it recorded in line with this, these potentials that we're recording on the polysomnography is it closes the deal. So very important to have that. Also night terrors, nightmares, very important. We feel like it's very important to have those recorded. It's also, these things that we have here is also necessary to be accredited through the Academy of Sleep Medicine, which Mercy Sleep Lab is. We are fully accredited through the American Academy of Sleep Medicine. So all these feeds from the patient are simultaneously recorded. And this is what it looks like. So I'm sorry, I know this looks like probably like a lot going on. Dr. Spivey did show you a little slide. Kind of going over it. Go back. So just to kind of touch on what we're looking at and why we're doing this, why we put all these leads on your child is to really solidify how well they're sleeping and if their sleep is fragmented. And if it is, why? It's not just apnea that we're looking for. It's the most common that we see is apnea or pauses in breathing. But we're looking for everything and anything. So I'm just going to kind of go over these really quick. So we put one by each eye. We have the left eye and the right eye, these blue ones that you see here. The way I review a study, I look at one hemisphere of the brain, even though we put leads on both hemisphere of the brain, both sides of the brain there. So we have, like this lead is in the front of the front part of the scalp. This is in the central, and then this one is in the back of the brain, or on the back side of the brain, the occipital region. But there are different brain waves associated with different stages of sleep. And then here's that muscle tone. You'll see this increase when the mouth is being, moved or open. So moving on, we have the pulse rate, which you can see the EKG or the heart rhythm here. Very important for us to see that because sleep disorders, especially sleep apnea, can contribute to certain arrhythmias in the heart and problems in the heart, the breathing. So right here we have our limbs, these two brown ones. So if there was activity, you'd see the muscle tone, just like you see in this EMG here, fluctuating here and here, or somewhere in here. And then we have a microphone. This is the snore microphone. So this picks up actual vibration in the airway, this one. And then we have a flow, which is a cannula that we place in the child's nose, which is always saved for last because it can be a little heavy for a little person to take on, to be applying that. We'll talk a little bit about that. But so you'll see here, the next, we have the nasal breathing here, oral breathing efforts. And then we have the chest. This is what I was talking about before. So we have that belt that goes on the patient's chest. And then we have the abdomen here. So that's the one that's showing us how well the stomach's working. These are what's called intercostals. They look at the muscles in between the ribs. So we'll see when a person's taking a bigger breath, we'll see those increase. And when they're limited, we'll see it decrease. This is the oxygen level. This patient is staying pretty low. But there's the reason for this patient being there is because if you can see, we're taking some breaths, we're snoring, we stop snoring. Snoring helps keep that airway open by vibrating that tissue, the tonsils, the adenoids, and even the tongue kind of vibrates. So we can get air down at times. It's kind of a self-defense mechanism, very obtrusive to your bed partner, but that's kind of the body trying to make sure it gets some air. So you can see it just drops out here and it goes out, and you can see this is the end of what's called a desaturation. So this patient went down to 79 here, most likely from a baseline of 95. This person just can't get it back up. So this one, just this little page, or what we call an epic, shows us an obstruction. But this is a polysomnography, and that's what we're looking at when we're viewing the child in the control room. Stages of sleep, like I said, the EEG, the eyes, and the muscle tone in the chin, and sometimes breathing. We can see the different stages of sleep, and just these are the two that really you can see a difference in to a person that's not used to seeing this. This is called slow wave sleep. Very important. It's our most unconscious stage of sleep. It's the one if you wake your child up out of, they'll become very groggy. This is also the stage of sleep that usually precedes a night terror. And the patient, you'll still see these brain waves, right? You'll still see this, and you'll actually see muscle tone coming in here, and they'll maintain that. And it's the wildest thing, because if you've ever dealt with your child during a night terror, I mean, really, literally, they will look through you because they really don't know you're there. And they don't really care that you're there. They're just trying to get through what they're going through. And like Dr. Spivey said, you will not recognize, the child would never know that was the case in the morning. Sorry. So that is stage 3, very important. And then stage 4, which is known, everybody might know this one. This is REM. So we see rapid eye movement. Sorry about that, I had to step away. So we see the eyes, we can see this rapid eye movement, kind of like for most of us in kindergarten, we paint on one page, fold the paper, open it up, and we'd see these eye movements. So this is actually the person looking left, right, blinking through here. So they're dreaming of something. It's called phasic REM, and they're actually, something's going on where they're actually moving the eyes accordingly. And what we'll see too here is the brain waves kind of change. So I'm just gonna go back really quick, back and forth. So these are the two that you'll see a major difference in, and these are highly important for the success of the person physically or health-wise. We need to see these two, and they need to not be interrupted. So it's very important that the patient is getting those. So with the sleep study, with all these wires, I do have to touch on the fact that it's not always easy. For the age group we're speaking of, it's very rare, and I don't mean anything against the boys or the male population, but the female patient is a lot more on board usually with this than the boys. Just from my experience and my other technologists' experience, it's pretty surprising that the young ladies can handle it a little bit better than the males. You know, the idea is here at Mercy, we want that child to be a part of it, right? So we want them, and this does help us in the long run, because the idea is to bring them into the operation itself, helping us maybe put some goop on a wire to be placed on the head. They can do that. We actually let them prep sites. We have to prep the sites, you know, things like that. We let them plug the electrode into the head box. Very important that they feel like they're involved. Now, that's not always necessary. Some kids just want to have their iPad, and you can do whatever you want, and that's about it. But we do try to include them, which leads me to another thing. It is highly important, and it makes the whole thing more, I guess, a little more successful or easier, is the involvement of the parent. The parent can be a big contributor to success or to adding fear to the child, believe it or not. And you know, if so we have to include the parent too, and we do. We want to make sure the parent's involved. The parent is there through the whole hookup. We're in the room doing the hookup. So we really try to let the parent know that everything's gonna be all right. Nothing hurts the child. It does, if there's sensory issues, which we deal with a lot, then there's times where there's a little less prepping done because we're rubbing skin and we're cleaning these sites to apply these sensors. So we do recognize that. Part of what I do is I review the patients coming in for the night. Laura and I, my partner, the coordinator, we review the patients before the techs get there. And before that, Dr. Spivey or the referring physician will definitely make sure we're aware in their consultations if there's any kind of behavioral concerns or there's any sensory issues, you know, anything congenital that can be a contributing factor to having issues that night. So we take that into account. I make sure the techs are aware of that, even though they do get the chart with the patient and they'll review that. I just touch on it with them and make sure that, you know, they know what to expect. We definitely highlight all that for the technician, and the technicians really know how to, I'm really blessed to have the staff that I have working with me, because they do. They bring that child into the moment and they try to get that child involved in it. It doesn't always work, but most of the time it does. I can tell you this, I can promise you this. If I'm sure one of us, besides Dr. Spivey and I, has been through a sleep study. I think, I'm pretty sure at least one. But I can promise you this because I've done it so many times through my life. The first time I did a sleep study, I was like, I cannot believe I'm doing this to people. But once these wires are on me, which are over 20, there's about 20 different leads going on. Once I fell asleep, I never woke up because of the wires. If I woke up, it was because I had to use the restroom. And it never stopped me from falling back asleep because that would usually, for the patients, just being in a foreign place. It's more like that. So I can promise you that your child's never going to even know those are on them while they're sleeping. We don't see on a sleep study itself those wires waking that child up or that patient up. We see something that contributes to an arousal, and then that can contribute to either having difficulties reinitiating sleep, or they just fall right back asleep, literally in 2 to 3 seconds or 4 to 5 seconds, and they're gone. We do have times where a patient or pediatric patient will wake up, and because they're in a foreign place, and it's just like us at a hotel, we might wake up a little scared at first, but because wires are on these children, it kind of adds to it. So there are times in the middle of the night where a child will wake up suddenly, and not just a night terror or something like that, but they'll wake up, recognize they're in a foreign place, and forget that we even put those on them, and that can get a little hectic for a while. But once the parent hopefully has calmed them down, they usually fall right back asleep. So again, I promise you, none of this wakes them up. It does take some time to get them set up. The idea is we have the patients arrive here at around 7:30, the pediatric patient, and then we're usually with you. We give you time to acclimate to the room, you and your child, and then it's about 45 minutes, depending on the participation of the parent and the patient. 45 minutes to an hour for a hookup. There's things that we have to do to make sure we're deliberate and that the signals look like they should for that interpreting physician, which Dr. Spivey is one of those. And let's see. So the final process, the study is finalized and ended around 6:15. All the leads are removed. There's a questionnaire to be completed out by the attending guardian or parent. There are amenities here. We have the shower in that room also. So if you guys wanted to do that or clean up before you leave, we have all that for you. The data is then, besides being scored at night partially by the attending technologist, the data is reviewed and scored kind of like with a fine-tooth comb during the day. And that data gets processed into a report, highlighting arousals, highlighting events, highlighting gritting or grinding of the teeth, heart arrhythmias, issues with the heart, limb movements, things like that, and more. I'm probably forgetting quite a few right now, but there's more to it. Snoring, the percentage of snoring. How often does that person or that pediatric snore? It's pretty important. Yeah, so it usually takes about 2 business days for the interpreting physician to read. A call is then placed, or to receive that, for that data to be scored. 2 business days for the interpreting physician to get that. Sorry, I've misworded that. So it takes about 2 business days for us to score that data or score that study, produce the report, and then what happens is Dr. Spivey or Dr. Chu Kang will review that data. They will actually look at the physical data, and they will give their dictation, and the idea is to contact the parent or guardian with the results. So, it's like it says here, every child, every need, every day. It's really important for me that we are successful as a pediatric lab, because like I said, for me, there's a passion in making sure we get to somebody as soon as possible, because sleep and health, you can't have one without the other, really. If you think about it, where do we physically and mentally heal? There are stages of sleep that the exact reason why we get those stages is not set in stone, but we know if we take away these stages, the body and the mind fails. So someday, the hope is someday that any pediatrician, any primary care physician, they will start with their patient's sleep and see how they're sleeping, and go from there. I really feel like I've been rambling, but I am very passionate about it. But it's nice for us to be involved in the pediatric world, and we look to really promote that, as a department here at Mercy Hospital. Other than that, I don't think I have anything. If you guys have any questions, please feel free to ask. I think we can talk about the idea of scheduling, what happens there. And if there's any other questions, please just ask. Thank you, guys.
Thank you. Lots of great information. You shared, Jonathan, again, so we definitely appreciate it. I personally learned a whole bunch tonight. I've heard about it, but never actually saw the room or saw what really goes on. So again, thank you. Does anybody have any questions, Jonathan or John?
I can't get you guys back up for some. Oh, wait, here we go.
Jonathan, John says, great job.
Thanks, Dr. Spivey. Let me see. Oh, I am sharing my screen. Let's not share my screen anymore. There we go. There is everybody.
Any questions?
One thing I will say on top of Jonathan's PowerPoint is, as you've seen with the first lecture and the second lecture, again, kids are not tiny adults. So how you go about the sleep study, how you, different leads for pediatrics and adults, how you score the sleep study is different. So I think going to a sleep provider that, obviously if you're pediatrics, go to a pediatric sleep center. Jonathan does an amazing job with our sleep, and as the beneficiary of getting that data, what I know is the data that I'm going to get is the best possible data. You can imagine these kids often are pulling off their leads, they're doing all sorts of things, and that's why in pediatrics we don't do a lot of home studies. You can imagine for typical sleep apnea for older adults, they're getting a study at home because you can put on leads, you can go to sleep, and you can get that data. But our technicians are working so hard. Often it's a one-to-one, so one technician to one subject, and they're really monitoring these kids really well. So, again, we say this time and time again, kids are just different. And, I thank Jonathan for letting me be a part of this, because it really is, we're passionate about what we do. And he always does such a great job with our sleep patients. So I'm able to look at the data, then evaluate the data and the quality of that. So yeah, thank you.
Thanks, Doctor.
I can tell you both are very passionate about what you all do. So we definitely appreciate all your expertise and your experiences to definitely share with our families tonight. Again, thank you.
You're welcome. Yeah. You're welcome.
All the PAT families, thanks again for joining us tonight. Please look at our website. Our next group connection we're having for families is actually next week. Our regulation relationships part 2 with Stacy is the 16th at 6 o'clock. Join us for that. Also, I'll invite you all too, John and Jonathan, and your families as well. We have done a virtual family fun event, and we have hidden 12 wooden candy canes in the Wentzville area. And so I encourage you to go and check them out and find them. There's rhymes and clues on our website of all 12 locations, little clues for them to go and find. Take a picture and then send it to us via the Google form, and then you'll be entered into a drawing for some great prizes from different places in the area, different small businesses as well. So go and have fun hunting. So
that's cool. Yeah.
Well, again, thank you all again. We appreciate it. And I appreciate you sharing information with us there on your PowerPoints. And I'm sure families have a question or concern, they can definitely, give you a call or send you an email. So thanks again.
Yeah, please just feel free to reach out. We feel pretty blessed that we were contacted. So thank you, Adele. We appreciate you reaching out to us. And yeah, we're on board anytime you guys need anything that we can help in. We this is what we know. So this is definitely a highlight of what we get to do. So
Again,
thanks.
I will tell you, families here have shared. Thanks again so much. It's great information that you all shared. They have some work to do with their own families.
Yeah.
Thanks again.
Oh, yes. Thank you so much. I really appreciate it. I'm glad it all worked out, and we will be in contact for another one for sure.
Awesome.
Thank you.
Yeah, thanks, Adele. Appreciate it. Thank you, Julie.
No
Appreciate
problem. All right. Take care. Have a good night.
You too.
Bye.
Good night,
Thank
Dr.
you.
Spivey.
Thanks for all you do.
Good night, everybody. Good night.
You're
Thank you.
welcome.